So how do you deliver life-saving medication to a patch of tissue that has basically walled itself off behind this impenetrable microscopic bunker of solid keratin?
Yeah, that is, I mean, it's one of the most frustrating paradoxes in dermatology, honestly,
Yeah.
because you're no longer just managing localized inflammation,
Right, exactly. You're fighting the severe physical obstruction. The frontline treatments basically just bounce right off the tissue.
which forces doctors to completely abandon their typical protocols. They have to bring in this controversial systemic drug to literally force the skin to rewrite its own architectural blueprints.
It's wild. Welcome to today's deep dive into the source material, everyone. Today we are looking at a scenario where the standard, highly effective clinical playbook just entirely breaks down.
And we've got a fantastic stack of sources for this one, including clinical guidelines from the British Association of Dermatologists, Euroguiderm, plus some really fascinating clinical trials and medical case studies. We do. And our mission for today's deep dive is to answer a highly specific, but honestly critical medical question. When is systemic therapy with oral acitretin or other systemic retinoids clinically indicated for severe hyperkeratotic variants of genital or extragenital lichen sclerosus?
Which is quite a mouthful, I know, but it's such a critical juncture in patient care because, we're really examining how dermatologists weigh the risks and rewards of bringing out the heavy artillery.
Yeah, and why you, listening to this, should care. I mean, even if you don't have this condition, understanding how doctors escalate care for treatment-resistant diseases is just a fascinating look into the art and science of medicine.
It really is. You're moving from a relatively safe topical approach to a systemic therapy that actually alters cellular transcription across your entire body.
Okay, let's unpack this by starting with the baseline. Let's look at the standard line of defense before we get into how and why it fails. So we're talking about lichen sclerosus, or LS.
Right, which is a chronic inflammatory dermatosis. It causes these sclerotic, atrophic, usually hypopigmented or whitish plaques.
And it mostly affects the anogenital region in both men and women, right?
Yeah.
But it can pop up on other parts of the body too, which is called extragenital.
Exactly. And the consensus guidelines are pretty unified on how to fight it first. The gold standard, the frontline defense, is almost always ultra-potent topical corticosteroids.
Like clobetasol propionate, right? Applied straight to the skin.
Yeah, clobetasol. Because it's basically a massive immunosuppressive hammer. By applying it directly to those plaques, you're essentially cutting the power to the cellular alarm system.
Right, it halts the cytokine storm, stops the aggressive T-cell response, and just gives the tissue a chance to breathe and stabilize.
Exactly. And for the vast majority of patients, that works. Topicals usually keep the disease in remission just fine.
But, and this is big but, our sources today are focused on the outliers. If topical steroids are like a surface-level weed killer, what happens when the weeds have incredibly deep, thick roots?
Yeah, that's when you run into the severe acute cases that are recalcitrant. Treatment resistant.
And specifically, we're looking at patients who develop what the sources call hyperkeratotic variants.
Right, hyperkeratotic,
Mm-hmm.
which basically means the skin becomes extremely thickened and scaly. The pathology drives this massive, unregulated buildup of the stratum corneum.
Because the skin cells, the keratinocytes, they hyperproliferate, and then they fail to shed normally.
Exactly. They fail to desquamate. So you end up with a profoundly thickened, heavily scaled plaque that physically alters the architecture of the epidermis.
So if a topical corticosteroid's whole job relies on transdermal absorption the drug has to physically soak through the skin to reach the inflammation. That thick scale just ruins it.
It acts like a concrete bunker. The clobetasol ointment basically just sits on the surface of the scales doing absolutely nothing.
Wow. So you hit a literal pharmacological wall. The drug might be perfect for the inflammation, but it can't actually get there.
Which is exactly why the guidelines state that when the disease becomes this severe, widespread, or just totally refuses to respond to topical steroids, the clinical indication shifts.
You have to bypass that barrier completely. You need a systemic inside-out approach, right?
Right. You need an oral medication delivered via the bloodstream that can dismantle that keratin wall from the bottom up.
Which brings us to the heavy artillery. Enter acitretin.
Acitretin, yeah. It's the primary systemic drug highlighted across our sources. It's an oral synthetic retinoid, which is basically a vitamin A derivative.
And the text mentioned it actually replaced an older drug called etretinate. Right?
It did, yeah. Etretinate was highly lipophilic. It stored itself in the body's fat for months or even years. Acitretin is its primary active metabolite, and it has a slightly better pharmacokinetic profile.
Oh, wait, I have to push back here for a second. The sources say acitretin is FDA approved for severe psoriasis.
Yeah, that's right.
But psoriasis and LS are totally different conditions with different immunologic drivers. So why use a psoriasis drug here? How does it actually break down these thick, fibrotic LS plaques?
Oh, this is the really cool part. It comes down to how retinoids function at the cellular level. They aren't just anti-inflammatories, they are brilliant at modulating keratinization, which is the process of skin cell turnover.
So they basically tell the skin cells how to behave.
Exactly. They bind directly to nuclear receptors in the cells and alter gene transcription. And in severe LS, there's a specific imbalance in retinoic acid receptors, specifically RRR alpha and RRR gamma.
Wait, so the receptors themselves are dysregulated in LS patients?
Yes. The tissue is basically receiving flawed instructions. So by introducing a potent retinoid like acitretin, you override that broken pathway. You
Yeah.
force the cells to normalize their turnover rate.
And it doesn't just stop at shedding the thick skin, right? The biochemical data mentions CD44,
Oh, the CD44 expression is huge. Retinoids dramatically increase the expression of epidermal CD44.
which is a glycoprotein involved in cell adhesion and maintaining the tissue matrix, right?
Exactly. So while you are forcing the bad hyperkeratotic skin to shed, you're simultaneously handing the underlying cells the scaffolding they need to rebuild healthy tissue architecture.
Here's where it gets really interesting, though, because theoretical science is great, but let's look at the proof in the patients, the clinical trials.
Right, let's look at the real-world evidence for this off-label use, starting with the BOSMA trial from 1994.
Okay, break that one down for us.
So this was a double-blind, placebo-controlled study of 46 women with severe vulvar lichen sclerosus.
And double-blind is so important there because subjective symptom reporting can totally skew dermatology trials.
Absolutely. So they used doses of 20 to 30 milligrams a day for 16 weeks. And the results were fantastic. They saw significant reductions in pruritus or itching, but also real physical changes.
Like actual reduction in the atrophy and the hyperkeratosis compared to the placebo group.
Yeah, the transcriptomic reprogramming actually worked to dismantle the barricades.
And then there's the Ioannis trial from 2010, which focused on the male presentation.
Right. 52 men with severe, long-standing LS of the male genitalia. They gave them a slightly higher dose, 35 milligrams daily for 20 weeks.
20 weeks.
Yeah.
And treating chronic, long-standing disease is notoriously hard because the tissue has already scarred and remodeled itself.
It is, but they still saw a massive drop in clinical severity scores and a hugely significant improvement in the patient's quality of life.
But the case study that really brings this to life for me, and this is from a European Academy of Dermatology and Venereology abstract, is the pediatric case.
Oh, the 10-year-old girl. Yeah, that case is striking.
It's heartbreaking, really.
Hmm.
She presented with this extremely rare, generalized extragenital LS.
Yeah.
The description says she had these shiny sclerotic papules covering her limbs, her back, abdomen, just everywhere.
And trying to treat a full-body flare-up in a 10-year-old with topical steroids is basically impossible.
If you'd have to cover so much surface area, her body would absorb way too much of the
Yeah,
steroid.
exactly. You cause severe systemic immunosuppression, stunt her growth, mess with her bone density. It's a non-starter.
So they were forced to use systemic steroids, oral prednisone, just to calm the massive flare-up initially.
Which works as a rescue therapy, like a fire extinguisher. But you can't keep a child on prednisone for months on end.
Right, so as the steroids wore off, they needed a bridge. And that's when they added acitretin at a very low pediatric dose, just 10 milligrams a day.
And it was an incredibly effective maintenance bridge. They kept her on that 10 milligram dose for a full year.
A whole year with no recurrence of the widespread lesions.
Exactly. It shows that acitretin can act as a firewall to keep the disease at bay without the devastating long-term side effects of systemic steroids.
But that forces the critical so what question, right?
Yeah.
If acitretin works this incredibly well for thick, stubborn plaques and can clear up a full-body flare in a child for a year, why isn't it the very first thing doctors prescribe?
Well, that comes down to the catch, the guardrails. The very mechanism that makes it so effective at changing cellular differentiation also makes it inherently dangerous.
We're talking about the side effects. It's classified as a second-line or last resort therapy for a reason.
A very big reason. The primary issue is teratogenicity. It causes severe, life-threatening birth defects.
And the guidelines are incredibly strict about this. Pregnancy has to be completely avoided during treatment, obviously, but also for 2 to 3 years after stopping the drug.
Wait, 2 to 3 years?
Yeah, because remember how it's lipophilic. It stores in the fat cells and slowly leaches out over years. Plus, if a patient drinks alcohol, acitretin can actually convert back into a tretinoid in the liver, which lasts even longer.
Wow, so that strictly excludes a massive portion of the patient population right off the bat, just due to the exhaustive contraceptive protocols required.
Exactly. And even if pregnancy isn't a factor, the systemic toxicity profile is intense. The sources highlight severe Zika symptoms.
Right, extreme dryness, dry cracking lips, dry skin, and severe ocular dryness that can actually threaten your eyes.
And it doesn't stop there. It can elevate liver enzymes, and it frequently spikes cholesterol and triglycerides.
So the doctor is essentially forced into this constant state of surveillance, running lipid panels, checking the liver, making sure the drug isn't destroying the patient's internal baseline while it fixes their skin.
Which is why the final clinical consensus from both Euroguiderm and the British Association of Dermatologists is so guarded. They only give systemic retinoids a week or suggested recommendation.
Right. For men, women, and extragenital patients, it's only recommended when systemic therapy is absolutely needed, meaning the disease is severe, hyperkeratotic, and standard topicals have completely failed.
And it has to be prescribed by an experienced dermatologist who knows how to walk that razor's edge.
Exactly.
So what does this all mean for you listening? It means systemic retinoids like oral acitretin are clinically indicated as the heavy-duty backup plan. When LS becomes severe, hyperkeratotic, or extragenital, and it just laughs at topical steroids, acitretin steps in to literally rewrite the skin's turnover process.
It's the ultimate architectural reset button.
It really is. And I think this deep dive perfectly illustrates how modern medicine works. Borrowing a tool designed for one job like psoriasis and carefully deploying it to solve this rare, stubborn problem in another area. It's this constant, delicate balance between dramatic healing potential and severe risks.
And honestly, it leaves us with a really fascinating thought to ponder for the future.
Oh, yeah. What's that?
Well, if systemic retinoids can fundamentally alter the skin's blueprint by changing cellular receptors like RAR-alpha and CD44 to reverse severe hyperkeratosis, could future treatments involve targeted, localized genetic manipulation?
Oh, wow. Like utilizing Serenade directly into the plaques.
Exactly. Could we eventually cure the root cause of the thickening by manipulating those exact pathways right at the lesion site? We could completely remove the need for these heavy-duty systemic drugs and avoid all that systemic toxicity entirely.
Dismantling the concrete bunker with surgical precision instead of, bombing the whole system. That is an incredible thought to end on. Thank you all for joining us on this deep dive into the sources, and as always, stay curious.